treatment of hypertension. Is hypertension curable? Who said yes? Which hypertension is curable? It's the secondary hypertension which is curable. Primary hypertension or essential hypertension is not curable. It's just a manageable disease. Now there is an interesting statement about hypertension. The greatest danger to a man with high blood pressure lies in its discovery. Patient is asymptomatic. Patient doesn't have any problem. One day is found that I am hypertensive. The problem starts. Because then some fool is certain to try his hand and reduce it. So when you start treating, patient starts having symptoms. Essential hypertension, until and unless complicated, is asymptomatic. But when you start a treatment, patient starts getting these side effects and patients start becoming symptomatic. You start a diuretic, the bladder starts complaining frequently. The blood sugar may become erratic, the lipid profile may be disturbed, the uric acid may go up. Electrolytes are disturbed in old ages. This may be a problem. Patient may have hyponatremia and go into unconsciousness. You start beta blockers, patient starts having fatigue. There may be nightmares, patient may have impotence. You start calcium channel blockers, patient starts swelling up, gets constipated. You start ACE inhibitors, patient starts coughing. You start ARBs, patient may start having postural symptoms. So the patient was all right and patient says, I am in a trouble now, what have you started, doctor? I was all right and now your tablets have started causing me trouble. I was better without tablet. So how to convince these people that you need treatment? These side effects of these drugs are far less than the complications hypertension is going to cause you in the long term. Why to treat? It's top 10 risk factors for global mortality. You can see raised blood pressure is the most attributable cause towards human mortality. When you see the top 10 causes, hypertension is the most important. And you see the prevalence is going to increase. By 2025, it will be 1.5 billion, and the way the world's population is increasing, I guess it's going to be even more than that. And you see the highest growth in blood pressure patients is in the southern hemisphere. The Latin Americas, the Africas, the South Asia, the Middle East, and the East Asia and Pacific. You see the highest problem is going to be in the southern hemisphere, and we are living in southern hemisphere. So this may be a big problem for us. We already see the statistics in our country are very, very dismal. You see almost 1/3 of the population above the age of 45 is suffering from hypertension, and only of these, probably 30% or even less are diagnosed as hypertensive. And even worse than this is, out of these, only 3% patients are on goal. So they are not well controlled, they are very poorly controlled. The situation is very bad. Today is 8th June, 28th May is the World Hypertension Day, and this is being celebrated today in our university, and we are having a program on hypertension in the audiovisual room. If anybody wants to join, Professor Azizur Rahman is going to give a talk on hypertension. Consequences are damage to these organs, the brain, the heart, the kidney, the peripheral vessels, the eye. So they can be danger anywhere. And you see, what is the advantage of treating? Increasing blood pressure increases the risk of death from stroke. You can see that both rise in systolic and diastolic pressure increases the mortality. Systolic blood pressure is more related with strokes than diastolic blood pressure. But even with the rise in diastolic pressure, you see there is increase in the mortality from the strokes. Similarly, we see the cardiovascular mortality, and you can see this also increases with increasing blood pressure. This is data from Mr. Fit. Millimeters do matter, and you can read this 115 by 75, 130 by 85. It means 20 by 10 millimeters, the risk doubles. For another 20 by 10 millimeters, the risk becomes 4 times. For another 20 by 10 millimeters, the risk becomes 8 times. So as the blood pressure keeps on increasing, the risk from stroke and cardiovascular death goes on increasing. Just a mere reduction of 2 millimeter in systolic blood pressure, it reduces the cardiovascular mortality and the stroke risk by 7 to 10%. So CV risk and the stroke risk, just by attaining a very small decrease in blood pressure, can result in decrease in these two conditions, that is cardiovascular mortality and stroke, by a significant number, 7 to 10%. So it is important. So that's what you have to understand. There may be side effects of the drug, there may be cost implications of using the treatment, but there is a definite advantage. So we find that treatment is, in one word, cost effective. So whatever we are spending, we are bearing, is useful. So the treatment available for hypertension is cost effective, and that's why it is recommended that all patients who are diagnosed as hypertensive should be treated. The targets should be achieved. Now, the treatment for blood pressure, like other chronic illnesses, is both pharmacological and non-pharmacological. For example, you see diabetes. The treatment is non-pharmacological as well as pharmacological. So what is the non-pharmacological treatment for hypertension? What is this DASH? DASH and AE. DASH, yes. DASH is dietary approaches to stop hypertension, and A is aerobic exercise. So this is the hallmark of non-pharmacological treatment. So dietary approaches to stopping hypertension is the DASH. Now, what is the composition of the DASH diet? It includes fruits and vegetables, low-fat dairy milk, fish as main part of the diet planning. Aerobic exercise, 30 minutes of aerobic exercise daily for at least 5 days in a week. So 150 minutes of aerobic exercise per week. You can have it daily 5 days, or you can have 3 days a week, 50 minutes on alternate days. So this is your choice how you can convince the patient that patient should exercise. Healthy low-calorie diets, sodium intake has to be reduced to less than 6 grams. Aerobic exercise, relaxation therapies, decreasing the alcohol consumption, coffee consumption. Calcium, magnesium, and potassium, which were once thought that supplementation might help in controlling blood pressure, so they are no longer recommended as an adjunct to treatment of hypertension. They may be given if the patient needs them for other indications, not for hypertension and smoking. So this is the lifestyle intervention which every hypertensive patient requires throughout the course of his disease. As long as the patient is alive, all these interventions are required. Now, you've got pharmacological treatment. What drugs are available for antihypertensive treatment? Treatment for hypertension, what drugs are available? Can anybody name what are the class of drugs which are available? ACE inhibitors, ARBs, beta blockers, calcium channel blockers, which diuretics? Thiazide type diuretics, alpha blockers, centrally acting drugs, direct vasodilators. Do we have a new drug available for hypertension in the recent past? One was direct renin inhibitor, which is now out of the market. Now there is another drug which is being approved possibly for hypertension. It's a new drug in the market in the last, I think, couple of years. Aldosterone synthase inhibitor, Baxdrostat. We'll see how does it work. So these are the different class of drugs which are available. Diuretics, mostly thiazide type of diuretics. We can also have potassium sparing diuretics, particularly in patients who got heart failure. Calcium channel blockers, angiotensin converting enzyme inhibitors, angiotensin blockers, alpha blockers, direct renin inhibitors, and aldosterone synthase inhibitors. And you got direct vasodilators as well. Now, what is the recommendation of using the drug? Number one, in general non-black population, including those with diabetes, initial treatment can be started with any of this class. Thiazide diuretics, calcium channel blockers, ACE inhibitors, or ARBs. Remember, ACE inhibitors and ARBs are never added together. It is either an ACE inhibitor or an ARB. So it is not ACE inhibitor and an ARB. So three class of drugs can be used in a given patient. In blacks, including those with diabetes, initial antihypertensive treatment should include a thiazide type diuretic or a calcium channel blocker. ACE inhibitors or ARB is the second choice in blacks. Now what we are whites or blacks? We are closer to blacks. So in our population, it should be the calcium channel blocker and the thiazide type diuretic, which should be the first choice when you start antihypertensive therapy. The main objective of hypertension treatment is to attain and maintain blood pressure goal. We will see what are our goals, where is the blood pressure is required to stay at what target levels. We will see. If blood pressure goal is not reached within a month of treatment, increase the dose of the initial drug or add a second drug from the classes which are given. The clinician should continue to assess blood pressure and adjust the treatment regimen until blood pressure goal is achieved. Now what happens in what we see in our clinical practice, that antihypertensive treatment is started and both physician and the patient, they do not follow it to take the treatment to a level where target blood pressure is met. We just start, patients do not monitor, and so do we. We just have a false sense of security that we have started an antihypertensive treatment, the patient is going to be all right. So it is a continuous process. The patient should be instructed to religiously follow, so that the target level is not only achieved, it is maintained for long term. So that is where you get the benefit. If the target is not maintained, you do not get all sort of benefits which I mentioned in the previous slides. Now the goals of treatment have been different. Over years, they have been different goals, and different societies have been issuing their guidelines that this should be the optimum control, this is the target we need in this sort of population. So this is the target by the American Society of Hypertension and International Society of Hypertension, ASH and ISH combined. So this was, I think, published in 2014 on 15. And then we've got more recent guidelines given by, for example, American Diabetes Association or other associations. So we just see they are almost similar. They are exactly not the same, but they are similar. So you follow one of these guidelines, see what target you should be eyeing at. Adults ages between 18 and 79 years, the blood pressure should be less than 140 or 90 millimeters of mercury. And in younger subjects, for example, if a patient is 55 years old, you can have a target of less than 130 or 80 millimeters of mercury. And patients who are over the age of 80 years, the target is to reduce the blood pressure to less than or equal to 150 over 90. So for younger patients, the targets are a little more stringent as compared to the older patients. And when out of this population you see patients who are diabetics, the targets become even more strict. The optimum blood pressure for a diabetic may be it is 120 by 80 or less than 130 and 80. For a patient with a kidney disease, a similar target may be required. So out of this population, then we can see which populations are at increased risk of having complications. For example, diabetics and patients who got kidney disease. The blood pressure targets become even more tighter in this group of population. So these are our general goals, that we keep it less than 140/90 or better if it is less than 130 or 90 in younger subjects. And patients who are 80 years or old, it is 150 or 90. Patients' blood pressure should remain below 150 or 90. So these are our targets. Now, when do we add a second drug? You see, monotherapy fails to achieve goal in 70% of the patients. So single drug generally is not sufficient in all patients. In a very small number of patients, a single drug, those with a mild hypertension, single drug may be enough to control the blood pressure. But studies indicate that most of the patients, they require 2 or 3 drugs to control the blood pressures. Now these are various studies. For example, it is MDRD, HOT, RENAL, OSC, ABCD, IDNT, UK, PDS, SCOT, PPLA, LHOT, and accomplished trials. So they all show that in most of the cases, achieving these systolic blood pressure target goals, 132, 138 or similar number, we require most of the time more than one drug. So a single drug is not generally able to control blood pressure in most of the patients, and we may require a second or a third drug. If blood pressure goal cannot be achieved with 2 drugs, add and titrate a third drug from the list provided. Now, do not use ACE inhibitors and ARB together in the same patient. Now, what we see when we add drugs, we try to see that these drugs, if they can complement each other, that will be more useful. For example, if we combine an ACE inhibitor or an ARB with a calcium channel blocker, what sort of advantage we are going to get? Not only these 2 drugs, they augment themselves according to their mode of action. They also help in controlling some of the side effects. For example, calcium channel blockers, they cause edema, while ACE inhibitors, they can reduce this edema. Maybe they are unable to eliminate it, but they may reduce this edema. So they complement each other not only in their pharmacological actions, they also complement in their side effect profile. So you can choose drugs which can help each other in attaining our goal and preventing the side effects. If goal blood pressure cannot be reached using the drugs because of contraindication or a need to use more than 3 drugs to reach the BP goal, antihypertensive drugs from other classes can be added. So out of the 4 classes which we saw, diuretics, calcium channel blockers, ACE inhibitors or ARBs. So practically we have 3 classes. It's ACE inhibitors or ARBs and 2 other classes. If out of these 3 classes the blood pressure is not achieved, then we can go for other class. For example, we can go for an alpha blocker or a centrally acting drug or a vasodilator. adding a second agent is more effective than titrating up the single agent. So one theory of uh, treating the hypertensive patient is to start one drug and take this drug to its maximum tolerated dose, and if not controlled, add the second drug. But from this treatment philosophy, we find that the side effect profile tends to increase. So if adding to a small dose of first drug, we add a smaller dose of a second drug, this is more beneficial than titrating up the single dose and getting better results with a combination of drugs. Now these are NICE guidelines. What is NICE? NICE guidelines, just remember, they come from the United Kingdom. We divide, you see, lifestyle changes, they continue for whatever treatment you are offering. They are part of every treatment. It does not mean that if you have started a pharmacological treatment, lifestyle modification has lost its importance. It remains there. It is important throughout the patient's life that the compliance with the non-pharmacological treatment should continue. We divide the patient into two groups, less than 55 years and more than 55 years, or black patients. Patients who are less than 55 years and they are not blacks, they are whites. You can start with A. A is ACE inhibitor or an ARB. While in patients who are more than 55 years or black, you can start with a calcium channel blocker. Then, if not controlled, you can add these two drugs, ACE inhibitor oblique ARB plus calcium channel blocker. If this is not controlled, you can add a third drug, that is diuretic. And if it is not controlled, you can add an alpha blocker, a beta blocker, a centrally acting drug. And if this is not controlled, even with this, patient is compliant with lifestyle and with the treatment, and the blood pressure is still not being controlled, patient should be referred to a blood pressure specialist where renal denervation may be considered, that you denervate both kidneys, so that may control the blood pressure. So that comes the surgical intervention, that may be transcatheter or that may be other way. So, but this is how we go when we start a patient treatment for hypertension. And then you got a scene where you can choose drugs with compelling indications. If a patient has a reason to start a particular drug, for example, if a hypertensive patient has angina, beta blockers are the drugs which are chosen for angina. So the patient can be started with a beta blocker. That was a general scheme for patients who don't have any other reason for any other organ symptom or any other complications present. Beta blockers with angina, ACE inhibitors or ARBs for a diabetic patient who's got microalbuminuria, because ACE inhibitors and ARBs, they can reverse microalbuminuria. Diuretic in a patient with a fluid overload, and alpha blockers in a patient with prostatic enlargement. So you can consider drugs out of that scheme if the patient has a very compelling reason for starting those drugs. So these are a few examples in which we see that drug other than the classes we mentioned or other than the scheme we mentioned in the NICE guidelines can be used. Then monitoring the compliance. Now what is that affects the compliance is patient education, the side effect profile, the cost and the pill burden. So all these, they affect the compliance. You see, what is the cost of treatment of a hypertensive patient per day in our setup? Do you have an idea what is the cost? If you buy a leading, or what we say the original manufacturer of a drug of hypertensive class, for example, valsartan or losartan, what is the daily cost of a single pill? It's around 80 rupees. So if you need another drug, cost goes over 100 rupees. But fortunately, we have got generics, which are far more cheaper. But still, in a country where 60% of the population is lying below the poverty line, and the treatment cost per day is quite a bit for those populations. So we have to think something about the cost as well in patients who cannot. Then side effect profile, maybe we can educate the patient that these side effect profile, even if bothering, in the long term may be more beneficial with continuing this treatment. And then obviously pill burden is a problem, and older patients taking multiple pills. So if you can design drugs in a single pill combinations, they may be useful. And now we have got drugs which are available in single pill combination. For example, all three drugs, thiazide type diuretics, calcium channel blockers, and ACE inhibitors or ARBs, they are available in single pill combinations. So you need only one pill with different strengths available. So pill burden can be reduced by just combining the drugs in a single pill. So this is about the treatment of hypertension. Actually, hypertension is a big subject. I have tried to reduce it to fit in a small period of time, because now we have not seen hypertensive emergencies. What are hypertensive emergencies? How to deal with hypertensive emergencies? Now, what are hypertensive emergencies?